So I will start in English now, and I'm not going to give a long presentation about you guys. You are more than welcome to do that yourself, but we're very, very happy that this session could be organized and that you were able to join us today. And so mainly talk about, of course, your what do you say, journey with care bundles at Oxford, and the floor is yours, and just go ahead. And of course, or maybe it's good to be muted during your presentation, but ask questions. That's what we're here for today, so that you will get the most out of Giles. Thank you.
Yeah, so before I start, just want to say thank you so much for allowing me the opportunity to speak to you about something that I absolutely love. I've spent the last, well over a decade now, looking at ways to improve sort of patient outcomes. So let me try and share a screen, just there. So look, by trade, I'm a surgeon, and I'm a liver and pancreatic surgeon, liver transplant surgeon, and I did all my training in London, as well as at the Mayo in America, and then I've been lucky enough to end up in Oxford. And I thought today what I would do is tell you my story from my journey of arriving in Oxford, and how that went for me, because it wasn't great when I first arrived, if I'm honest. Everything I'm about to say, just so you know, two things, right? You can have this presentation, so don't worry about having to make any notes or anything like that. Everything that I'm about to say, I've summarized in this article for Journal of Wound Care, which you can look at if you wanted to, but you can have the presentation. And also at the end, you've got all my contact details. So please just email me directly if there's any questions that you're not sure about or too shy to ask in front of everybody else. Otherwise, go into the chat box, or we'll just ask questions as we're going along. But at the end, we'll definitely have some time to talk through any points that you need. So I arrived in Oxford from London, and I arrived in the liver and pancreatic unit. And Oxford is a fabulous global institution, and they don't like London, because London think they're the best, Oxford think they're the best, and when you try and move from London to Oxford, there's often a lot of rivalry. But anyway, I managed to get appointed, and I arrived, and I thought it was just fabulous. I thought this was going to be the best place in the world. But the first thing that I noticed, almost within a few days, was on the wards, there are an abnormal rate of surgical site infections. Almost every patient that I was walking to in a bay had some sort of surgical site infection, SSI. Now, in liver and pancreatic surgery, just to use that as an example, the problem with surgical site infections is they're the most common cause of delaying patients to get postoperative chemotherapy. So if I do a pancreatic cancer operation, take someone's pancreatic cancer out, that's fabulous. But their length of survival only depends on them getting chemotherapy within an optimal time frame, typically 6 weeks after an operation. If I miss that optimal time to chemotherapy, some people would argue you shouldn't have done the operation in the first place, because your length of survival is so badly affected. So it's got a really, really important role. But you can imagine in orthopedics, a surgical site infection that starts off superficially, getting into a joint, is catastrophic for the patient. They could increase your length of stay. You have a 60% increased risk of going to intensive care, which is incredibly expensive. You have a twofold increase of dying compared with background rates within your operation. And obviously there's risks of coming back to hospital Well, this is just rubbish for patients. We should be seeing them, operating, getting them out, and not having to have them come back for problems that are preventable, such as surgical site infections. Then let's just say they get over it. The risk of incisional hernia long term is very, very high in those patients that have had deep SSIs. So these surgical site infections, which to most junior surgeons are just, oh, it's nothing, just give them some antibiotics, it doesn't mean anything, are incredibly important. And there really are a marker of excellence. So look at this SSI rate, blimey. The reported rate in the literature is in liver and pancreatic surgery is about 30 to 40%. I don't believe that anymore, if I'm honest. I've been around too many liver and pancreatic units, not just in the UK, but around the world, where actually we're around the 50 to 60%. And if you look here, when I arrived in Oxford, the first audit I did was 63% overall. 77%, over 3/4 of our pancreatic cancer patients, those are the Whipple's patients, were having some sort of surgical site infection post-operatively. Think about that. Almost all of them were getting a delay into chemotherapy. And that's why Oxford, in its outcome for long-term survival, time to chemotherapy, was not great within the UK rankings, you know, near the bottom. Bit awkward, really, because I was the London boy coming out into Oxford. They expected me to bow down and worship the mighty Oxford University. And within my first month, I'm telling them that they've got a problem. So they said, well, it's fine. Just sort it out, Giles. Just sort it out. If you're so good, if you know best, what would, make it work? And I had to explain, it's not as simple as it seems. Patients are complex. They're diabetic. They're immunocompromised. They've got cancer. They're too fat. They drink too much alcohol. They smoke. All of these things need to be optimized before we get into a theatre, because they all have detrimental effects on the outcome of the wound. There's lots of drugs that they may be on, but let's just forget all that. Let's talk about the actual surgery. Do you think that endocrine surgery, nice little nick under the neck there, has the same rate of infection as me doing a complex liver transplant? I mean, they don't. So even within different surgical specialties, there's different rates of surgical site infection. When I speak to my spinal surgeons, and you'll see some of the data later on, and I'm telling you, all this data is my data. Like, I'm ripping the Band-Aid off and telling you, this is how bad we were, purely because we get better. I think otherwise Emma wouldn't, and Johnson wouldn't have invited me along if I sort of said we're terrible still. But you understand that we get there. Even within different surgeries, there's different surgical site infection rates. So when our spinal surgeons turn around and said, but our infection rate is single digits, we can't do any better. Well, let's just see what happens. The other thing is that we work in theatre. And theatre is a complex, hostile environment. You have lots of different team members. You have lots of moving parts. You have surgeons focused on the body. You have scrub teams trying to bring in lots of different equipment. You have runners trying to set up diathermy, energy devices, laparoscopic, robotic surgery. The anaesthetist is at the head end with their assistant trying to ventilate the patient, running their machines. All of this, doors are opening, temperature is fluctuating, air cycling is happening. It is incredibly difficult to control that environment to optimize the surgical wound. But we can boil it down to one salient point. It's a battle. It is a fight between our immune system and the bacteria ability to form biofilm. If we can stop them forming biofilm, they can't protect themselves, and then all our devices, all our interventions will kill those bacteria, and they won't be able to form a surgical site infection. So everything I'm about to tell you from now on is about limiting the bacteria's ability to create biofilm and to promote our own immune system to attack them before they can get that biofilm. So I'm charged with this. My bosses, when I arrived, they turned around and said, we'll crack on with it. But I felt very alone. No one was interested. It's not sexy, who really cares? It's not my problem. It's something out in the community to sort out. I heard all these excuses, but Giles, our surgery is dirty. It's multifactorial. It's complex. Our patients have cancer. Our patients are immunocompromised. HPB surgery has high SSI rates. You should know that. And the worst excuse I heard, and it's really sad, is we've tried. And they've given up. They deep down, they knew they had a problem. They just didn't know how to turn it around. So I went to the wise. I went to the infection prevention control leaders. I went to the head of microbiology. I went to the head of surgical outcomes. In Oxford, we're full of academics. And I will tell you one thing, there's a book there by Chip and Dan, their siblings. And that book, I wish I'd read before I began this. It tells you how to influence people's behavior within a complex environment such as healthcare. And what I do say is that if you're married, you don't really want your partner reading this book, because you'll end up doing stuff that you don't even know you're meant to be doing. They will be able to change your behavior. Or if you are married, you may want to read it, and then you can go in and change your partner's behavior so that they're doing the washing up or whatever. It's a really good book, very easy to read. So look, what's the solution? What are we really thinking here? Well, where do we go? I tried to get back. I would tell you these points. You've got to get your own data. You've got to be prepared to get people knock you down, say, no, this is ridiculous. They'll get jealous, and they'll try and stop you. You've got to expect the unexpected. People come along and help you that you weren't expecting to help you. You cannot do this on your own. You need a team. And we'll talk about that in a minute. And at the end of the day, you've got to demonstrate a financial benefit, because in the UK, I cannot think of a project that I've got across the line without demonstrating some sort of cost saving. I honestly talk about our chief exec like champagne at Christmas, and all we've got to do is save enough money so that the chief exec and the board have a good Christmas party. The point is, if the solution is expensive, nothing's going to change, because no one will entertain it. They'll just stick with the status quo. And hopefully I'll be able to show you how we can make things saving. And the plan has to be KISS. Keep it simple, stupid. I don't know if my professor was talking to me personally, but we are educated individuals. On this conversation right now, we are all well in the top half of the population. We've got to allow for the fact that people are not as educated in surgical field, optimizing outcomes, how to protect the wound, prehabilitation. All these words, which I know are familiar to all you guys, are absolutely alien to some nurses on the ward, to porters, to junior doctors. We have to keep it simple so that everybody understands their role and can help. So the first thing I did, I got data. 2 months, followed every single patient up 30 days that were operated on for 2 months. That way, when I came to people and said, I think our surgical site infection rate is high, it wasn't me just guessing. I could put it down on the table. I said, here it is. It's 63%. And that really takes people's breath away. It makes them feel anxious. It makes them try and justify, look for excuses. That's okay. Let them do that. because we're going to give them the solution to make them look like absolute heroes. You have to put the information out to everybody, and that is not just at the surgeon. That's at the anaesthetists, the scrub team, the porters, the nurses on the ward, the physios. Everybody that is involved in the patient pathway has to know that we've got a problem. And explaining right at the beginning, what's the implication of having a surgical site infection? Delay to chemo. We're not going to improve survival. Long-term complications, incisional hernias. Those are $100,000 operations. Do you think my finance director wants to blow out 100 grand on an incisional hernia that could have been avoided? Of course not. So we just let everybody know. And we've got to build a team. And again, when I first started this, everybody just said, sure, Giles, go ahead, you do it. Nah, it's not going to work. The surgeon is not the only person in this. You have to put a whole team together. And you ask each team member to come up with one thing, one idea that they can change, that they can be responsible for. You can give them the evidence. All right, there's lots of different surgical bundles out there from the World Health Organization, from NICE, our National Institute of Clinical Excellence in the UK, from the CDC. There's lots and lots of information out there, which you can bundle together. And I did, and sent it to everybody and said, hey guys, look at this. Which thing do you think you can influence? And here's the other thing. When you challenge people to come up with a solution with just one idea, it's amazing how many people buy in. So there's the team. Look at that. Infection prevention control, very important. That team of nurses crosses every single discipline. Nurses on the wards, physios, surgical, anesthetic, theatre teams, they cover everybody. Microbiology. I took swabs from all my patients during the operation, our bile swabs, and sent them off to Micro. Micro then turned around and said, Giles, the antibiotics you need to give your patients are, and initially it was coamoxiclav, then it moved from coamoxiclav to metronidazole, then it became cefazolin. And the point is, we got absolute agreement with everybody about the correct antibiotic that we should be giving for our patients. So the infectious diseases, microbiology, surgeons, anaesthetists, and scrub team in the WHO meeting, which I know you're all aware of, where we talk about antibiotics, if the anaesthetist turned around and said, oh, I'm giving ertapenem, everybody in the room would go, no way, we know that the drug to give is cefazolin, please can you give that? And we bought in with everybody, and you can see that. Look at that. I've got procurement teams, hospital finance teams, junior and senior nursing and surgical teams, critical care. Everybody was included. And we got a great solution. But I did put some caveats. The solution can be no longer than 10 points. The World Health Organization is 28 plus points. You're never going to remember that many. We as surgeons find it difficult to count above 5. I know in scrubs, you count all your swabs out in 5s. We do that for a reason. It's easy to compartmentalize below 10. So let's look at a 5 to 10 point bundle. It's got to be evidence-based. There's no point me coming to you and saying, oh, we do it in Oxford because Oxford's the way that we do it. The world doesn't work like that. Every single thing I'm going to tell you has level 1 evidence. That's top of the pyramid, level 1 meta-analysis, randomized systematic reviews right at the top. And the other thing is, one job, one person. And hopefully you'll see that in a little bit. Because if I turn to someone in the room there now and said, hey, I want you to solve this. By the way, I need you to do 10 points in every operation in your hospital. It's never going to work. We've got to educate people so that each person has one job to do and they can look after it. And it can't be expensive. So our solution was basically cost neutral to the trust. We had all the parts, we just didn't do them all the time. We told everybody what their role was, what their expectations were, and then we told them that we would be auditing this in about a year's time. We advertised a clear start date, and we didn't touch anything for a year. And the reason being is we were sick and tired. How many, you guys must have this as well. You get a brand new manager who comes in, or a brand new surgeon who says, guess what we're going to do? We're going to do this. And everybody gets excited. And then 6 months later, 3 months later, 1 month later, someone new comes along and says, oh yeah, we're not going to do it like that. We're going to do it like this. And then it changes again and again. And we all get bored and tired of starting projects, but never seeing them complete, never understanding what the impact we had was. And then finally, when we, 1 year's time, when we re-audited, we would let everybody know the success and what the outcome was. So what's the plan? I've given you all the fluff and the bump, the drum roll. Well, it's easy. We are going to talk about an 8-point SSI reduction plan. Look at that, 8 points. You'll all be able to remember this by the end of it. I tell you, you will be able to. You won't need the presentation. It is that simple. In fact, it is so simple, you're going to turn around to me and say, but Giles, we already do that all the time. Let me take you through them. We got 5 points pre-op and 3 points on closing. Let me tell you what I mean by that. No surgeon is going to be told how to do an operation. I would not dare walk in to one of my colleagues and say, this is how you do a Whipple's operation, because the way that a surgeon does the operation is the best way that they know how to do that operation. So telling them to do a hand sewn or a stapled anastomosis, I'm not interested in that, right? Let the surgeon do the operation. But we can prep the patient in a way which the surgeon doesn't care about, but, well, he does care about it, but it's not going to influence his operation. And we can close the wound in a way that's not going to affect the operation. And the surgeons don't see this as antagonistic. So as scrub nurses, right, my scrub nurse, I mean, she's quite scary. I won't lie. I mean, she's incredibly intelligent, and she just, she runs our theatre so well that when it comes to closing, we all change our gloves, we all bow, and she tells us we're allowed to close once she's done all her swabs and needles and instrument checks. The point is that scrub nurse and her team of scrub nurses are all empowered to ensure that the surgical team close the wound in the same way each time. And we've had all that buy-in. So what are the points? Well, the first point, straightforward. You clip, you do not shave. The number of surgeons that still shave patients with a razor, it's terrible, right? And the other thing is we should be clipping the patient outside of theatre if you can. So we clip in the anaesthetic room. I'm not sure if you have anaesthetic rooms there, but if you don't have an anaesthetic room, ideally the patient should be clipped before coming into theatre, maybe up on the ward or in a holding bay. And the reason being is that when we clip the patient, we create quite a lot of debris that floats around, and it takes quite a lot of time to settle down. And that debris can land in the wound. So we want it outside. We definitely don't want to shave because that creates microabrasions. So even when you prep, those tiny little nicks, those tiny little cuts, which you can't necessarily see, allow skin flora, the bacteria, to get into those little microabrasions and start creating biofilm. So clip, don't shave, and ideally do it outside. We gave that job to our junior surgeon. Correct antibiotic, correct time. 2 people involved in this, the microbiologists, as I said, they look at our swabs on an annual basis, and then they just tell us, Giles, the local population around Oxford, the antibiotic profile, the microbiome has moved. we need to change our antibiotics. Please, can you give cefazolin? That's what they said this year, or sorry, last year, 23. And we need to give it at the correct time. There's no point giving it too early. There's definitely no point giving it too late. Ideally, you want to give it within 60 minutes of knife to skin. So we had to go and speak to the anaesthetist and say, when you're giving your anesthetic, please can you give the antibiotic at that point? I don't want to see anaesthetists giving antibiotics after we've made the skin incision. It negates the effect. So we educated them. Now, the anaesthetists give the correct antibiotic at the correct time. How about this? When I first turned up to Oxford, I used a set of antibiotics, and I just wondered what my colleagues used. And out of the 6 surgeons, we all used different antibiotics. But it got worse than that. Because I came from London, my anaesthetist didn't believe that I knew what I was talking about. So even though I said, could we give coamoxiclav, that anaesthetist turned around and went, no, he doesn't know what he's talking about. I'm going to give ticaplane and gentamicin metronidazole. So I didn't even know what antibiotics I had been giving. So it was insane. So now, total conformity. Everybody gives the same thing in the WHO checklist. When we talk about antibiotics, thank you, what time? 20 minutes ago, Giles. Which one? Cefazolin. Thank you very much. Not confrontational, always done. Warming, hardest one for us. We looked at our patients. We took 120 consecutive patients in Oxford for liver and pancreatic surgery. Not a single one, 0, were 36 degrees or above at the time of knife to skin. And the problem is that surgical site infection rates go up exponentially for every 0.1 of a degree below 36 we are. So I had patients that were 35 degrees, 35.3, 34.8. And that's because Oxford is a huge hospital where it's like Hogwarts. It's old, it's run down, it's not world-class looking by any means. We got to travel patients, sometimes take them 10 minutes, and they were coming down in a thin gown. No wonder they're cold. And then the anaesthetist is going to spend an hour, strip them naked, lines in, tube in, art line, everything, catheters. They're there for an hour. No wonder they're cold. So I said to the porters, I said, why don't you put blankets? And the porters turned around and said, the nurses on the ward won't let us have any blankets because the blankets, when they arrive in theatre, get put into the theatre washing machines. So they don't go back up to the ward. So the ward get penalised for giving blankets out. I said, this blew my mind. So we stopped all that. The porters were allowed to ask for blankets to keep the patients warm. But actually the porters turned around to me and said, but Giles, in the other half of the hospital, they have mobile bear huggers. Why don't we have them? Well, I mean, I had no idea that existed. And the hospital did have this. So we got mobile bear huggers. So the patients feel nice and warm on the ward. They feel secure. They're 36.5 when they're leaving the ward. They come down with the mobile warming blanket. They have all their lines put in. They're kept at 36 degrees. We now hover around 96 to 98% normothermia for all our patients across every single general surgical specialty. Liver and pancreas, so HPB, upper GI, esophagastric surgery, breast, endocrine, trauma, so emergency surgery, colorectal, all of those, we hover around 96, 98. Because of the porters, because the porters helped us understand the problem and solve it. And then we empowered the porters to come with it. So I am hugely grateful to the porters there. Normothermia is the anaesthetist assistant's job to make sure that when the patient arrives, they are normothermic, and then it is the anaesthetist's assistant job to ensure they're normothermic until time of knife to skin. Next, ChloraPrep. 2% chlorhexidine, that's what we use, that device there. Evidence-based, really easy. Alcohol, better than aqueous. Chlorhexidine, better than povoiodine. 2% alcoholic chlorhexidine is better than 5% alcoholic chlorhexidine. So we use 2% alcoholic chlorhexidine. The only skin prep that has an EU license, I still consider us part of the EU, is that device there. And guess what? We had it in Oxford. Again, we just didn't know. What we were using were the galley pots and the pink slosh. And, you know, there's lots to do with that. You obviously, grandfather rights, it's a very reasonable way to prep. The problem is it's not safe in terms of fires. You can slosh a lot of liquid onto the abdomen. It rains round the back or round the back of a leg. You use your diathermy, a fire kicks in. So we've had fires reported, as I'm sure you all hear. The other thing is that with that device, the sponge on the end of the device is really, really well designed to impregnate the chlorhexidine into the epidermal layers. When you use a normal swab, a normal gauze, it doesn't rub it in as well. And it's designed to dry really quickly. So none of this pour on, swash it around, wipe it off by the surgeon. That does no good. This allows you to really impregnate. Again, that's the surgeon's job. And then glycemic control. I would leave, if you're starting this project, I would leave this one alone. It is difficult to do, but what we're really looking for is tight glycemic control between 6 and 8 millimoles throughout the operation and for up to 48 hours afterwards, if they're an inpatient. If they're not and they're going home, fine. But this is a tight glycemic control even in non-diabetics. Anaesthetists find it very difficult to monitor this. They don't like doing it. So we actually have got a sort of a device that I'm sure you've seen on social media where people are sticking the patches on nowadays. It's very similar, and it Bluetooths every. I think it samples the capillary glucose somewhere in the region of 1,000 times a minute. And gives a reading that's very, very easy for us to pick up. It's difficult to do, and this came out as part of a research project that I was involved in, which is why we managed to do it. But it takes a lot of persuading from the anaesthetist to engage, and it's difficult. But it's got level 1 evidence, and the World Health Organization recommend it, and NICE recommend it. So it really, really is important, especially in long operations, to ensure that we can get tight glycemic control. It's 5 points. Everyone's got a job to do. Everyone knows what to do. Do the operation however you want to do it. Don't care. But when it comes to closing, and let's just talk about the abdomen here, because that's where I work. First thing, pause for gauze. It's a safety checkpoint. What happens is the scrub nurse, while they're counting their swabs, needles, and instruments, we wash out the abdomen with some warm normal saline until the scrub nurse tells us it's okay to close. And we call it pause for gauze. It's a buzzy name, and it's a safety point. We then close the abdominal main muscles with a suture, however you want to do it, and you wash the abdominal wound with aqueous. We're now moving into aqueous povoiodine. It penetrates the fat by about 3 millimeters, and it stops biofilm formation. So it's a good thing to wash the wound out with. There are other things on the market, but the only one that's got any evidence is this. We then close the abdominal wall in layers. Lots of different layers. In the UK, loads of people are obese now, so the abdominal wall can be sometimes, you know, really solid, and you've got to make sure that you've got great apposition throughout the abdominal wall. And the reason being is you want the fibroblasts to knit together as quickly as possible, because the quicker the fibroblasts can mesh the wound together, the biofilm can't form. If you just close the bottom and the skin, you're left with a dead space. And within this dead space, you can get seroma hematoma formation. Bacteria love that. They'll form their biofilm. The SSI begins. It's terrible. And we've actually used these antibacterial sutures because obviously there's good evidence for it. There's lots of randomized, I think there's over 30 randomized controlled trials showing that they work. They work up to 30%. Well, I tell you this, right? When I first started this, I had this bundle and we didn't use antibacterial sutures and we plateaued. And when I went to procurement and said, we'd like to use these antibacterial sutures, they said, no, they're very expensive and they don't work. I said, well, here's the evidence. The evidence says 20 to 30% reduction in SSI rates, blah, blah, blah. Giles, what's your SSI rate? Well, I could tell him. I could tell him on a daily, weekly, annual, quarterly, whatever he wanted to know. For about 5 years, we had plateaued. We were allowed to implement the sutures, and just that one change, we got a 20% reduction, as well as some other bits, and I'll tell you about that in a minute. My point I'm making here is that this bundle is adaptive. That's the beauty of it. The anaesthetists and microbiologists giving the antibiotics are allowed to change their antibiotics. If you felt that waxing was better evidenced than clipping, you could wax. You know, maybe with the clippers, you're thinking, hang on, has anybody got a device for suctioning the hair away, like a vacuum cleaner on a clipper? Well, they do exist, right? You could change that. Just like this point, our junior surgeon, who, you know, it's their time to shine. It's their moment to really show us how good they are at suturing and their basic surgical skills, knot tying, laying sutures flat, closing the wound to look as good as possible. And you get this zone of inhibition throughout the wound. So with your povoiodine and the antibacterial sutures, you see a massive drop in SSI rates because the biofilm cannot form. And then we use skin glue over the wound rather than dressings. Why? Because if you work in theatre, I know what you're all going to be, you'll all recognize this. The junior surgeon, they've just closed up their wound. They've put the dressing on. It looks amazing. Before the patient has left the theatre, the junior's lifting up the dressing just to make sure it looks okay. And then they put it back down. And then in recovery, they're lifting up the dressing to have a look, make sure it's okay and not bleeding. That can't happen. That is bad. They put the dressing on and leave it and forget about it. Well, if you use a glue like Dermabond, two things. One, you can see the wound straight away. It's easy. Second of all, it's breathable. It allows you to sweat and come through the glue. And it's got some antibacterial properties. The reason I really like it is for when we make stomas, the fecal material can slosh all over the abdomen. And I don't care because that glue is protecting it robustly because it's waterproof. Lots of the dressings that we used before that weren't, and you know, and you just end up feeling that the wound looks a bit dirty. 8 points. Does it work? Well, as I said, I'd look a bit of an idiot if I got all this way and then said, no, it didn't. Have you guys got any ideas? It did work. Look at that. 63%, I told you at the beginning, down to 22%. We're one of the lowest in the UK. That's at 30 days across all types of surgical site infection, superficial, deep, organ space. We reduced our length of stay of our liver and pancreatic patients from 11 days to 6 days. That is enough time for us to do another patient through that bed. So one of the solutions to the COVID backlog is actually improving your SSI rate to avoid readmissions, to get the patient home quicker, and therefore you can turn the beds quicker with more operations. The chief exec and the chief financial officer have never had finer champagne. We've saved millions across the trust. Just in the liver and pancreatic department, we've saved over £2 million in the last 5 years now. It's just amazing. So we've saved an absolute fortune. People turn around and you're sat there going, yeah, but it's Oxford, you know, blah, blah, blah. Does it work anywhere else? Well, I went around other departments within Oxford. General surgery. That's acute general surgery. Pretty messy, pretty dirty. I heard all the excuses. They had a 40% SSI rate. We're down to 4%. The best was neurosurgery, spine, and actually it was the neurospines. They said we're at 3%, and we won't get lower than that. We're one of the lowest in the UK. We introduced a bundle for them. We halved their SSI rate. Spinal surgery were at 10%. They were being put into special measures. They were panicking. People were going to stop operating. We got them down to 1.45%. We've just had our 23 data come out with below 1% for spinal surgery. Newcastle is a hospital up in the north of England. Look at them. They started at 72%, exactly the same as us in Oxford. Couldn't believe it. They're down at 32%. And I've just been hearing a couple of days ago that their 23 data looks like that they're below 25%. So they've come even further down. Closer to home for you guys, Estonia. One of my fellows in Estonia, he came, spent a year with me. So impressed with this. When he went back to Estonia, he took on the general surgery SSI rate in Estonia, and he has reduced the entire SSI rate in Estonia by 50%. This can be done. It can be done quickly, efficiently, and long term. When we had the bundle and we were sort of really analysing what else had happened, one thing we noted when we introduced the antibacterial sutures was that our anastomotic leak rate has reduced significantly, and our intra-abdominal collections have reduced significantly. And what we think is happening here is that when we join two bits of bowel together, if you get biofilm forming around the anastomosis site, it causes breakdown. In the same way that the skin breaks down and opens up, the anastomosis does the same. And we found putting the plus sutures with the triclosan in there stops the biofilm formation and has reduced our anastomotic leak rates. So the last thing that changed pancreatic anastomotic leak rates was a type of anastomosis called a Blumgart anastomosis, and that reduced anastomotic leak rates between 3 and 5%. And it changed the world overnight. Everybody moved instantly to the Blumgart technique. Well, I'm telling you, our rates, our data, we've reduced our pancreatic anastomotic leak rates by using this bundle by 20%. So big is that number, we had to get some independent academics to come along and just make sure that we'd screwed it up, miscounted. They came back and said, no, it looks like it could be 22%. So now we're just starting a multi-centered randomized controlled trial to really see if we're onto something here. Because I think if we can get pancreatic anastomotic leaks down, they're the highest risk of any anastomosis. Colorectal, esophagastric, all of those will then start coming on board for lack of, to reduce their anastomotic leak rate. including vascular. I mean, I appreciate vascular is very endovascular, but the open vascular anastomoses equally as important. So I hope you feel that listening to this, you've seen, I came to Oxford, it was terrible, but we've improved. Everybody listened. We took an evidence-based team approach to reduce our SSI rates, length of stay. We've reduced the finance costs, and we've improved patient satisfaction. Forget all of that. I'll go right back to my first slide. We've improved our time to chemotherapy, and we are now one of the best centres, not just in the UK, but in Europe, for time to chemotherapy, and our long-term survival rates are just through the roof. It is an amazing story. So look, please come and write to me. Come and visit. We would love to host you. I've got theatre staff, I've got nursing staff, I've got surgeons, I've got anaesthetists, ODAs. I've got anybody you want to meet. I can get you to meet. I will just say, I put this slide up. This was at a last conference I gave, and I said, what I will say is that building there is not the hospital. And then someone shouted out, "We know, it's your office." It's not my office. That's the university. I will show you around all of those places and take you to some of my favorite colleges where I'm a member and stuff. And we could have some really good fun and work collaboratively out of this, because I've done it with Estonia, I've done it with Lithuania, Latvia, where I've taken really good individuals and we've had massive, massive improvements. So I hope that all makes sense. I hope I didn't talk too fast. I hope you sort of can understand. You guys always speak English so beautifully. I'll answer any questions that you've got.
Yeah, thank you. It's so much, but it's yeah. I mean, I've listened to this before, but it's still, every time it sort of hits you, like it's crazy, the numbers that you're presenting. I actually saw that Per had wrote some questions in the chat, and I don't know if you can see them, or should I?
No, so I can see them. Yeah. So yeah. Do you know what? So it's that is how do you say that? Is it Per?
Per, you often say.
Is that how you say it? Have I said it bad?
It's close.
Okay, I'll just say legend. The
yeah.
That is such a fabulous question, because it's a nightmare, especially for big open surgery that's long term. So liver transplantation, 5-6 hour. Some of my abdominal wall reconstructions is 8 to 10 hours. It's very, very difficult. So it's really important that we ensure they're normothermic to start with. With the bear huggers, we use over and under. We've looked at underlay warming blankets, and that works very, very well. But we've now, I don't know if you guys have seen it, we've got this 3M, and I think I'm using a brand here, sorry. It's a continuous temperature monitoring device that tells you almost, I think it samples every second, what the temperature of the patient is throughout the operation. So you can see the temperature dipping down. And if it's dipping down too much, then the anaesthetist can turn up the heat and turn up the underwarmers to ensure that the patient comes back up. But it's very, very difficult. How about this? Cardiothoracic, they want to cool the patient. They chill the patient, right? So in some circumstances, it's actually beneficial to chill the patient, although I think that's a bit outdated in cardiothoracics now. My point is, so long as you set your expectations beforehand as to what you want to do. So yeah, we can't keep the patient normothermic throughout. So after the operation, we're rapidly going to make sure that they're warm, yada, yada. Then it helps. Hypothermia blunts the immune system. That's why it's bad. It shuts, the white cells can't mobilize, the wrong cytokines get released. It's a problem. And hence biofilm can then form, because the bacteria don't mind a cold temperature. They bring their biofilm over them, and that protects them from the external environment. So they don't care, whereas our innate immune system does. So yeah, we're not bad throughout the whole thing. We're looking in much more detail to how we can optimize that. So it's food for thought. So let me just go about the skin prep. Skin prep was, it was Maria Burmeister at the World Health Organization. They looked at, they did these big meta-analyses. So took all these randomized controlled trials, threw them all together, and then looked at what the outcome was between povoiodine and chlorhexidine. And chlorhexidine was the best. Then they looked at aqueous versus alcoholic solutions, and alcohol was the best. So we know we've got to go with an alcohol, a chlorhexidine in an alcohol solution for skin prep. This is in adults, because I know some of you are going to come at me and say, oh, but in our neonates and children, I buy that, right? But my expertise is in adults, not in neonates and pediatric, because there's slight nuances that we have to use there. Now, when they looked at what types of alcoholic chlorhexidine, there are lots of different percentages, 2, 5, 10, 18. You wash your hands in different concentration to the skin prep, for example. And the meta-analysis said that 2% alcoholic chlorhexidine was better than 5% chlorhexidine, which kind of, I mean, I would have thought the more alcoholic, the better. But it doesn't necessarily work like that, because at too high alcoholic concentrations, if you're not rubbing it in properly and using it properly, it can evaporate before it does anything worthwhile. Does that answer that question? And the reason that I say that is because that ChloraPrep device is a 2% alcoholic chlorhexidine. That's why I put it in there. And then I don't know if you've got, but you should have. We call it betadine. It's just iodine-based skin prep. Lots of people still use it. It's just not, don't get me wrong, you can use povoiodine skin prep. It's just not the best evidence-based skin prep. And what we're trying to be is the best of the best. There we go. What kind of bandage do we use, and for how long? So I don't use any bandages. I use skin glue. However, I use abdominal binders for my abdominal wall surgery. So any abdominal wall surgery gets a big, what's called a 3-band. It's got to go from here to here, right? There's no point having the smaller ones like this, or just the tiny ones that come around. They don't work. And the reason that we use the abdominal binders is because it stops seroma and hematoma formation and reduces pain for the patients. Patients wake up a lot more secure and feeling that they can move much quicker with an abdominal binder in. I don't mention it in anything that I talk about because it's an additional cost, and therefore I don't want to say things that put a financial burden onto people. But we have it on, they keep it on 24 hours a day for 2 weeks, and then after 2 weeks they can take it off at night, but they wear it for another 4 weeks after that. And it's amazing. We've seen patients getting up and walking around an early discharge. The amount of opioids that we use has reduced significantly, and seroma formation has reduced significantly. So that's really like, but otherwise we don't use any dressings or bandages outside of the glue. We just think that the glue is really good. Here's one thing that people say is, why don't you use staples? You can use staples. I've got no problem with using staples. The problem with staples is that if you need to take a staple out, the wound falls apart really quickly. So you can take 1, 2, 3, and the wound suddenly does that. With glue, you put a blade in and you can really accurately mark a very small hole to get the often fat necrosis or a little bit of purulent discharge out, put a bag over it, and the rest of the glue holds everything in place really well. Hence, we like the glue. But again, I know there's lots of evidence out there. People can take a view. Doesn't matter. Just get conformity. Try using your own dressings. Get everything plateaued, then move to glue and see what happens. It is amazing how you see sometimes it goes horribly wrong. Sometimes it goes much better than you're expecting. But it's a dynamic process. So you can change things, after a period of time.
Yeah, I think that's what we've heard with the other presenters that was on the day of the course, that you just need to start with something, keep it, and then you can make alternations.
Correct.
And then you will actually see what happens when you make the alternations as well. But it's the bundle that's the thing. The bundle makes it big things happen instead of just pointing.
Correct.
And then somebody
Absolutely.
maybe not following, and that type of.
The other thing is, when everybody just has one job, it allows the theatre staff to turn to the junior surgeons, say, have you clipped the patient outside up on the ward? Oh, I better go and do that. We're using this skin prep. No, we're not. Why not? The evidence says this is the best thing. And then when the surgeon turns around and says, I'm not going to engage, it's really easy. We had exactly that. But out of the 21 surgeons I've got in my department, I was able to show their SSI rate for each person. And there were some who were up here and others down here. And it was really obvious as to who was following the bundle and who wasn't. And gone are the days where I've done this for 20 years, therefore follow what I do. That doesn't exist anymore. We're better than that. We're better than that.
Yeah, because I think that the main, I guess, issue, because we've had, this is the second year we have this this course, and also there was the same questions last year. It's mainly about the hurdle of getting started and who needs to be on board. And we've been discussing a lot, we're using the term like who is wearing the hat. So everything that needs to be done, someone needs to have the hat on that is responsible. But then also in a sense, it feels like someone needs to have the hat to make sure that the other people is wearing their hat. You see what I mean? And that maybe creates some sort of a, like, who is the boss, if you see what I mean?
Sure.
And that can also create a bit of this, I don't know, disturbance.
It does. So I didn't mention it today because I don't know how far along it is coming in Scandinavia, but in conjunction with Johnson & Johnson, I've developed a surgical site infection app, which allows surveillance of every single operation, every single patient, and it's done by the patient. So there's very little input from the clinician. But when you're onboarding, when you're uploading the patient, which happens in theatre real time, you turn around and you say to the scrub nurse, was chloroprep used with the antibiotic? You say to the anaesthetist, with the antibiotics given? You say to the assistant, what was the temperature, stay above 36? Yeah. And you tick all this down. And the beauty is we've done 250 cases with this app now, and I can pick out on what day there is a guy called Gary is the operating department assistant, because he doesn't believe in normothermia. And every time the patients are cold. And concurrently, on those days, the patients have a 15% increased risk of a surgical site infection. So I then take that data and go along and say, don't want him in the, we've got to educate him. No one wants to humiliate anybody or anything like that. But you can't argue with your own data. And it's as clear as day. Tell me how it's going. Well, now he's understood and gone, okay, fine, I better play the game. You need a champion rather than a boss. So you need someone in theatre, scrub, being the champion. You need someone within anaesthetics who's a champion. You definitely need a surgeon, be it within general surgery, within orthopedics, within endocrine, who's a champion. because the champions educate their entire junior team and empower them to challenge people when things haven't been done. Look, people come in to my theatre, you know, when I'm operating, I'm there 35.8 degrees, okay? So I don't operate. I sit there. That's okay. And we just sit there and wait for the temperature to come up to 36 degrees. It takes 15 minutes. The blowers are on, but everybody knows that. My juniors do that. And they do it because they know they've got my backing, they've got the team's backing, scrub nurse is happy, the anaesthetist is happy, the management's happy, because the outcomes can be catastrophic, especially in orthopedics where you're putting big joints in, or cardiothoracics, you know, where you're getting big sternal infections. These are hundreds and hundreds of thousands of pounds worth of problem coming, as well as, you know, affecting the patient. But the one job, one person makes everything much easier. It really does. Because when I go away on holiday, it can't all fall apart. That's the problem. It has to be a culture. And what we're talking about in that bundle is a behavioral change bundle. That's what all of that stuff. You do the audit, one job, one person, you re-audit, make sure everyone's comfortable. That constant reinforcement process takes about 100 days for it to become normal. And if you read that book, it tells you all about it.
Okay. Well, thank you. Actually, it's 4 minutes past now. So if we were supposed to, and now we will let you go as well. But I'm just going to say, just so you know, because what we made the group do during the holiday time since the course is to actually measure, just to be able to just show something to, I don't know who's interested, but just to be able to make a change and just show. For example, they've been measuring temperature, and they've also been saying how they are doing their clipping of the hair. And with the measurement of the temperature, I mean, I can say because I've got all the data, and yeah, it was not 100%, of course. And it's just that then you actually have something, and then you can actually go to someone and show, like, we maybe should do something here. And then you can show different types of bundles that we have, for example, yours or the breast surgeon that we listened to the other time. So it's just to be able to, you know, start. I think that's the biggest hurdle.
It is. And if you, one theatre, one team, that's how I started, you know, and I just got the anaesthetist and the scrub. Scrub was really important. The scrub nurses were instrumental in not being afraid to tell the surgeon, you're not using that prep, this is the prep we're using. They were instrumental saying, get out. If you want to clip that patient, push them back out. You're not coming in until they're clipped. They were really empowered to do that. And it was great. They're allowed to. They're right. You know?
Yeah. And I think that's the empowerment that is needed.
Really, it is, you know, and it doesn't need to be confrontational. It's absolutely fine. Okay, if you want to use Providing, it's great. Let me give you the evidence to email him, you know, or the surgeon or whatever, who's being difficult, you know. It's I think, look, I think you're going to have great success, and at the end of the day, everybody wants to be on a winning team. And if you can halve your surgical site infection rate, which you will do, you implement that bundle, you'll see a 50% reduction. It just happens all over the place. It really does. I think you'd be absolutely fabulous. Please come and visit Oxford.
Yes, I would love to.
We do hold symposiums and things like that. You know, it'd be lovely to come and meet some of the infection prevention control nurses, some of the theatre staff and things like that, so you can swap stories, you know. Any questions, just email me. You can have the presentation. Emma, thank you so much. No, thank you.
Thank you over again. We will share the presentation, of course, with the team.